All right. Well, everyone, my name is Mitchell DeShazer. I'm a licensed marriage and family therapist here in Shawnee, Oklahoma. Um, when I was asked to present on here, I was at the time working for Gateway to Prevention and Recovery, which is an outpatient substance use treatment facility. They serve most of Pot and Lincoln County, but they have sites in Seminole and one in Chandler, which is in the Lincoln County area. And we serve and treat people with substance use disorders and co-occurring disorders. They also treat opioid use disorder with medicated assisted treatment. And then a lot of the referrals there were like mandated drug court, uh, probation, like Oklahoma community sentencing, DHS referrals, and then we would have self referrals, people who would just kind of walk in, wanting assistance and help. And so part of my role there at the time um, was to do assessments and intakes, um, work with a clinical team to provide recommendations, do group therapy. I also did individual therapy. But part of my role that kind of grew there was working with families. And so they had periodically they've been around for quite some time. And periodically they would have LPCs or social workers who would work with families. But at the time when I was hired 2.5 years ago, they didn't have anyone. One of the therapists was doing some couples therapy, but there wasn't really anybody, primarily working with parents and their children, whether they were like adult children or kids. And so part of my role was to be able to provide services for families so that they could kind of understand how like addiction and recovery, how that kind of can impact the family, and how recovery really can, be strengthened if family members are involved. And so, and so that's what I have done for the last 2.5 years. Prior to that, I worked for an early Head Start agents. Well, it was an agency that also provided early Head Starts here in Oklahoma. So they had not only in Pot County and Seminole County, but they had early Head Starts in Cleveland and Comanche counties here in Oklahoma. And that's through they're called Crossroads. And so I would go in and work with preschool aged kids and their families. That was kind of short term. I was also doing some private practice work as I was going through and getting supervised clinically. So now I have recently started in the last 2 weeks. I'm out now the assistant clinical director with Shawnee Youth and Family Resource Center. And so part of my role there is we're developing programs, and I'm just kind of coming in and providing leadership, working with people as well, but and with families, but also providing leadership to other clinicians who are, in the field. And then we also are a part of a collaborative in Shawnee or Pot and Lincoln County that provides school-based services for students. And so we go into schools in South Pottawatomie County and in northern Pottawatomie County and part of South Lincoln County to provide services for kids who may not have insurance or whose families may not be thinking, hey, I need to take my kid, or as a family, we need to go to therapy. And so teachers who are there, they'll be like, hey, we've noticed that this kid, this student is having some either emotional disturbances or drug and alcohol use. And so they'll refer them. And then we work with other agencies like North Care, Red Rock, Gateway. I think those are the ones right now that are currently in the collaborative to provide services for those kids. So I guess I don't know if I think I answered that question. That was my really long intro.
That's fantastic. Thank you.
Yeah.
So we're just interested in hearing what drew you to this area of the field and how you got there and what training it took, I suppose.
Ah, okay, awesome. Um, okay, so I actually went to school in my undergrad for family psychology and art. That was back in 2001, and graduated in 2006. So I had from OBU actually, and afterwards had no idea what I wanted to do. But I had a former teacher say, "Hey, there's an open teaching position. Would you be interested?" So I was like, "Yeah, I don't have a job. I'll just go for it." So I went thinking that that was going to be kind of a temporary job, but actually fell in love with it and started teaching. So I've taught actually from 2006 to 2016, 17 in Tecumseh Public Schools, and was a fine arts teacher and tennis coach, and loved it. I taught high school kids how to, make pottery and do visual art and draw, and it was a really wonderful experience. Through that experience, though, I started noticing that a lot of the kids who were in my class were creating art, and it was a way for them to express things about themselves and their feelings and thoughts and emotions in ways that maybe they couldn't do verbally, although some of them had very good verbal skills too. And kind of in the midst of that, found myself just felt a calling to really shift and pivot my career after some prayer and listening to God and going back to school. So I actually went back to school. OBU had a MFT program that was kind of blossoming. It had already started, but talked to Kanan Crane, and he was like, "Hey, you should try this out." So I jumped in and did the fast track, which was like a 2-year program at the time, and that was kind of the process. So did that, and then went under supervision, and then was licensed. Hmm. Did I answer that question?
Yes, thank you.
I'm very visual, so not having anything in front of me is like, okay, I'll start rambling. So if I start rambling, I'm trying to watch everybody's nonverbals so that they don't like fall asleep, because I'm used to listening to people, not like
Huh.
a lot of talking.
Well, we're all therapists or therapist wannabes, and so we all
Yeah.
love listening. So I think we're just loving listening to you.
Well,
So what drew you to drug and alcohol in particular, or how did you get involved in that?
okay. So the drug and alcohol field was not like an initial passion of mine. I actually, it was, there was an opportunity that arose when I was working in the early Head Start for a position to do school-based services with kids. And that's kind of was my initial passion. It was like, hey, I would love to go work in the schools, because part of my history personally, one of the reasons that drew me to psychology in undergrad and then eventually to do grad school was that I I came from a lot of trauma growing up, and my family has a history of drug and alcohol addiction and recovery. And it was a school-based counselor who made contact with me. I really feel like God kind of brought that into my life while I was in late middle school, high school, that really helped change the course and the direction of a lot of systemic patterns that were in my family. And so when I had this opportunity to maybe do some school-based services, it was through the collaborative I spoke about, and that was through the Partners in Caring, and Gateway, which was one of the agencies here in the county, was hiring. And so when I started, I thought that a lot of my work was going to be in the schools, and they were like, well, in addition to doing that, we also, we'll need you to do some other services with our facility. And I was like, awesome, I would love to work with families. I don't care if they're babies or old people, and whatever their concerns are, I'll go for it. And so once I started doing that, it was a learning process, but I also found that a lot of my own personal experiences and myself as the therapist had to really, do some things. I connected a lot with the clients, and kind of loved it. I mean, and fell in love with that population. There were some challenges, and there are challenges with working with, I think, addiction and recovery in that population, just like there are with other populations. And so I had to go back to therapy myself and deal with some things, and work on some of my own stuff so that I didn't like have any kind of like counter transference issues. And so that's what kind of drew me, and part of that process, and working with people who have addictions to things, whether it's substances or other behaviors. I learned that was a little bit different than like working with families who may have other disorders or challenges.
Thank you so much for sharing that. If we students wanted to kind of pursue this path, are there specific steps, or are there multiple roads that kind of lead to the same thing? If you could walk us through the process if we were to pursue a drug and alcohol focus.
Yeah, awesome. And I would thank you for that question and the questions for leading. If you guys that are on here, because I see 3 other people, if you guys have questions and stuff, I don't know if that's like kind of for later or now, but if y'all hear me say something, I mean, I'm not an expert, but in like drug and alcohol, but I have had experiences, and I would be happy to answer any questions that come up for you guys. So feel free to chime in. I know it's weird hearing myself talk. So, okay, so the path. So honestly, if you're licensed or under supervision, there are quite a few agencies that will hire you. They don't expect you to be a licensed alcohol and drug counselor before you can work in a facility. So I think, having some training, in your grad school, or doing some research to kind of get yourself kind of acclimated to the process would be helpful. But I would say, like, honestly, for me, I mean, I've studied addiction when I was in school. Some of it was on my own, and some of it was in the coursework that I did. But I learned so much just kind of getting involved. So like once I got there, I was kind of like thrown in the water, and I just learned to swim in it. And some of it was personal experience, because I knew what some of this process was. But you'll get trained. A lot of agencies want to try to prepare their clinicians who are coming in, and so they will do training. The state of Oklahoma does require clinicians to be trained in assessment techniques. So the Oklahoma Department of Mental Health and Substance Abuse Services, they have certain assessments that they kind of expect to be used. One of those is the Addiction Severity Index. And so they do kind of, when you go in and do an assessment in most agencies, that's kind of going to be the template that you're going to use. I use my systemic, assessment skills too, but they kind of want, that's the paper they want when you send it, for them to fund, especially like people who aren't coming in and going to privately pay. They expect you to kind of have some understanding of, I want to make sure that I'm saying this right. It's ASAM is the acronym. And I think that stands for the American, oh my gosh, I just went blank. Okay. We call it ASAM because that's just, apparently you're talking a lot of acronyms whenever you get into clinical work. So it has to do with substance abuse medicine. So I think it's the American Association of Substance Abuse Medicine. I'm probably wrong, so y'all can look it up. But it's ASAM. And Oklahoma has the Oklahoma Determination of ASAM Service Level, which is a type of assessment that they kind of expect clinicians to be familiar with. You get training with it when you go into work into an agency. The state will actually pay for it, and they call it an ODASL, which I always want to do this when they say ODASL, because I think of spirit fingers. But that kind of help them, the state, pay for a level of care. So they kind of expect a clinician to be able to come in and at least be willing to learn that, or have some knowledge of it. So I'd certainly say that if you've never heard of the ASI or the ODASL, Oklahoma Determination of ASAM Service Level, that you look it up. You can get printed off free or get a PDF off of this Oklahoma ODMH website. Other training, I mean, I don't know. Motivational interviewing is a lot like solution focused theory to me. And so you'll see that thrown around a lot. But motivational interviewing, if you're not familiar with it, might be a good something to study and to look into, because people do come into treatment with varying levels of motivation. Some of them, they aren't all like just raring to go when they come to a treatment facility, because DHS, most of them are coming because one, DHS has taken their children, or they're on probation and they were positive for drugs or alcohol in one of their drug tests, or they caught some charges and there was a felony, and as a result, they were being offered by their county, at least in Pot and Lincoln County, offered drug court. And so some of them come in at kind of that pre-contemplative or contemplative stage of motivation, if you're kind of thinking in that theoretical, that way of thinking, that approach. And so you kind of notice them soften and become more motivated for therapy as they move through the process. Some of them, it takes them a long time, and then some of them, they get really motivated and then they kind of taper off. And so, but being kind of aware of that is kind of helpful. So some people like to go get trained as an alcohol and drug counselor. I honestly think, personally, this is my personal opinion, that you guys being in an MFT program are probably going to be very well equipped, and it'll be just sort of a matter of maybe getting just a little extra training and maybe doing some reading. But most of you who are probably here today, you're probably motivated. I don't know. Are you guys motivated to work with people with substance use disorders or addiction? Yeah. Awesome.
I'm not sure what I want to do yet.
Okay. That's awesome.
Personally, I am not just substance abuse. I'm motivated to work with delinquency, with people going through delinquency and stuff like that. So drug abuse is part of it, and I'm motivated towards that direction.
Okay. You said delinquency. Do you mean like younger people, adolescents?
Younger people, actually, mostly. Yeah.
Awesome.
Drug abuse is part of it. Yeah.
Very cool. There is a model that the state of Oklahoma has been really pushing for adolescents, and that is the community reinforcement approach. It can actually be something that's kind of more rehabilitative. So like taught, the acronym is ACRA. It's very solution focused, has a motivational interviewing kind of component to it, can be very therapeutic, but there's a high evidence based for it. And that's part of you just saying that just made me think of that model, or that approach. It's an approach. It's not it's an integrative model, I guess. That's awesome. And is it Rochelle? Is that, make sure, did I say your name right?
Yes, it's Rochelle. Yes,
Rochelle. It is. And you're kind of just getting a feel for everything, it sounds like.
Yes, pretty much. I really want to work with couples, but in what aspect, I'm not sure yet. So I thought I'd join in on as well and see or hear exactly what you have to say about it.
Yeah, definitely. I worked with, that probably was my highest clientele at Gateway, was couples.
Oh, really?
Yep. So a lot of spouses, they either came in both together because they were both seeking treatment, or one would come with the other because they found out that their spouse had an addiction and they wanted them to get fixed so that they could be a better partner.
Thank you, because I didn't think about it in that aspect. Was one coming to help or support the other one? So, or possibly both of them having an addiction. So thank you. Keep that in mind. I do have one quick question, if you don't mind. I didn't mean to just stop you, but so far what I've noticed in the program, and this is just my first year, there's a lot of acronyms, as you mentioned earlier. Is there like a list somewhere that has all of, because so far I've just been trying to keep track as I'm going through my readings.
Yeah.
But is there like some main list or something that we can pull from somewhere? Do you know, Megan? Muted. You're muted.
Yeah, I'm not sure about that, but it is a new world with a new language for sure.
It is.
I'll
Definitely.
tell you this, I don't know where any list is, and if anyone finds one, I would love to see it. I have to just ask and Google. Like, Google is like my best friend.
I've literally just been putting it together, and I'm like, okay, I learned this one, so.
Yeah. That's good. Those are great questions. It's nice to meet you guys. So it's Rochelle, Valerie, and then what's your name, sir? Vince? Is it Vincent?
Yep, that's Vincent.
Nice. How do you say your last name, Vincent?
Try it.
Ngafison?
Yeah, that's a good try. Yeah, you just silence the N and go just with the G.
Ngafison?
Yeah, Ngafison.
Oh, great job.
That's awesome. I like that. Very cool. Any other questions or like
Yeah, sorry, I had a question. So the LADC, that's what you mentioned, is just kind of an extra, maybe not necessary step, but it might be some more training. Is there any benefit to having that? Like, would it open any doors for opportunities?
Mm-hmm. Yeah, so the licensed alcohol and drug counselor can be something that an agency would look at and go, oh, you're an LMFT and an LADC. So that looks good. I don't think it's necessary. Now, however, unless if an agency, so for certain agencies in the state of Oklahoma, so this, I'm not really familiar with other states, but in the state of Oklahoma, for certain agencies to be considered accredited by as an accredited state agency, I'm gonna make sure I say this correctly, or CARF accredited, you have to have a or to be called a rehab. So that's the language. You have to have an LADC on your team. And so unless you're just trying to get that extra credential, I mean, I don't have it. I mean, I honestly, it does take some extra school time, and you know, I think does require some supervision and a test. I think I'm gonna tread lightly there because I don't know all of the certification process for that, but it can look good on your resume, especially if you are trying to maybe get into a particular rehab or a place that focuses on substance use, or you yourself are maybe trying to create your own agency and start it up. I mean, if you had it, then you could actually be like, hey, I'm going to start my own agency and get accredited and as a rehab center, and you would already have that, so you wouldn't have to worry about finding one, I guess.
You know, I know you said you don't have that particular thing, but like I wouldn't even know where to find a program or whatever. Is that like an online thing, or where would one maybe find that?
You could probably find some online schools. I'm trying to think of schools in the area. A lot of the LADCs that we had at Gateway, they were going to East Central University, which is in Ada, I believe, yeah, in Ada. They have a program there. I would imagine there are other universities in the surrounding area that also provide that. ECU is just kind of the one that a lot of my colleagues that I worked with, that's where they got their training and were able to get enough of those hours to be able to do that. So it does require some classes. So there are some specific classes that I believe, at least in the state of Oklahoma, that the board requires. And you can find that on the state website. So I wish I knew more of information to give you.
No, that's okay. That is just interesting to hear about, because I didn't know if it was like, you know, a 1-year thing, or like, you know, I just didn't know anything about it. So it's good to hear.
Vincent?
Yeah.
Sorry.
Oh, no,
Vincent,
go ahead, please.
Yeah, it's still in line of the career thing. So obviously, before we graduate, we are expected to have to put in 500 or so hours of clinical. So I think that builds us a lot to become certified or something like that. But apart from that, when you are looking for a job, do they ever expect anything more? Do they expect you to have another more experience? Like, I mean, like as jobs always say, 1-year experience or stuff like that. When you are looking for a job after your MFT program, once you graduate, is it always a recommendation for an experience, or they just consider your clinical as experience?
So I'll make sure I understand what you're saying. So you're asking, you know, because you're getting 500 practicum hours, correct, for your grad school experience.
Yeah.
And so your question, what I'm hearing you say is that you're wondering if sometimes agencies are looking for you to have so many years of experience post-grad before they would hire you.
Mm-hmm. Mm-hmm.
Okay. So I would say that the answer to that is it depends. My perspective is kind of just with Gateway. I have a colleague and a friend who worked for a rehab center. It was a mental health and substance use rehab center in Oklahoma City, and now works at an inpatient facility in Oklahoma City. And he didn't have a lot of like post-grad school experience working in any substance use facilities or facilities that focused on treating substance use disorder solely. And so I think as long as you can kind of maybe communicate to them, you know, this is kind of my, you know, part of my training and what I have had experience in, and that you have a willingness to learn. Sometimes they're okay with that. Sometimes they may be looking for something different. And so I know, like, when they post job descriptions online, I know sometimes they say must have 2 years of, you know, experience in a drug and alcohol facility or something like that. So I would always, this is me personally, and what I did is I always would say, hey, I noticed this. I haven't had that, so I want to be upfront with that, but I'm also willing to learn, and I'm really good at what I do as an LMFT, or as an MFT at the time I was under supervision. And my training has prepared me for that. And so being able to kind of sell that part, or, you know, be confident in the experience that you do have, can sometimes go a long way. And sometimes if the facility is, you know, sometimes the facility will say, great, come on, you know, come on board. We'll help you. We'll help you with whatever other credentials that you need. And you can always ask them that when you interview them, or maybe when you follow up on your resume and something like that. So, yeah, because I didn't have, you know, any experience with that. I do know some MFTs who have communicated in their experiences that they will go to maybe a rehab center, and they will try to maybe do some intern work there, or apply to be a case manager, or a peer recovery support specialist. And that's kind of sometimes maybe their ticket and route into that kind of facility to work with that population. And it kind of gets their feet wet a little bit. They start to they can still do some of their clinical work, but it's maybe more in a rehab, doing groups, or maybe doing some intakes, or case management services for people. Yeah. Did that answer any question of yours, or maybe okay, good. I guess I'm needing some validation tonight. Sorry, I'm just gonna call that out.
You're doing an excellent job.
Feeling excited about this, but a little bit uncomfortable. So
Yeah. I feel like it's so awkward on Zoom too. Like, I'd rather just meet in a big room and just have a conversation. But
yeah,
so we appreciate you meeting
no problem.
in this pandemic way.
Yeah, of course. And
Yeah,
honestly, some of the services are like this. I know we did services with people for the last, from March till probably about June. Our facility only was open for intakes, and everything else was groups and sessions, and family was through this telehealth. So
Yeah. Well, I had 2 questions, but I wanted to see if Valerie or Rochelle or Vincent had any more questions before I asked.
I did have a question actually, and first I just want to say thank you for speaking and talking to us today, Mitchell. And my questions is like a 2-part question. So, what is like the most challenging part, and what is the most rewarding part of like working with families with alcohol and drug abuse?
Okay, yeah, that's a great question. So challenging and most rewarding. All right, so some of these are gonna kind of blend together. Probably one of the most challenging parts of working with families in these populations is consistency. You will have maybe the individual continue in their treatment because they're kind of either mandated or they themselves are motivated. And so sometimes the challenging part is having the family stay engaged. Depending on where the person is in their relationship with addiction and with recovery, they may be experiencing some moments of recurrent use. And that recurrent that pattern that they, because we know as systems, systems don't change fast, and you can apply pressure to the system either in therapy, or there's other entities that do that, but systems, sometimes it's a slower process. And when addiction has been a part of maybe a person's life for a long time, and maybe a part of the family's life, that recurrent use sometimes, they can take like 10 steps forward, and then they go back like 6 steps because the trust is broken again. And so part of the challenge is keeping them engaged, educating them up front as families that, hey, this can be a systemic thing, and part of their recovery is also like, it's not your fault, right? Because there's so many other dynamics that are involved with families when addiction is involved. And so being able to educate them to stay involved with the process, but also helping them develop boundaries and strengthen those so that they're engaging in more interdependent, interactions with one another, can be a challenge, because oftentimes the family will drop off because they'll come to 3 or 4 sessions, and then their partner or their child or their parent will have a recurrent use, and they're just like, well, therapy just doesn't work, because if it worked, they would stop using. And so sometimes it's kind of keeping them engaged is the challenging part, and trying to give a lot of education up front to say, hey, stick with this process. It's not an easy path, but it can create some changes. And so when they do that, that is rewarding. That is a rewarding aspect. Another challenge is, as a therapist, sticking with the process, making sure that you're taking care of yourself, because this clientele can be challenging, because of what the substances do to the functioning of the brain, and their maturity level, their motivation, and being able to also, and yourself, like, not getting sucked into all of that. Like, you know, we want to be present in that space this is how I think as a therapist. I want to be present with you in this space. I want to, you know, do things to help you with your either individual system or your family system to make some movement and change. But I can't work harder than the patient. We call them patients at Gateway, or clients, whatever you want to call them. I can't work harder than you. And it can be really easy that's the challenge, is sometimes, you know, knowing how much to work, how much do you let them work. And so that can be a challenge. And then I guess another rewarding thing about the work is that you can see a lot of change happen pretty quickly. So, I mean, if a person's continuing to come, then you know that their substance use has changed in some way. Either they're like, you know, have stopped using, or they're using less, or they're functioning better in their use. So, I mean, because if they're maintaining their like engagement with services, their system is changing. And so I think that that's a rewarding part of it. And in my time at Gateway, it was really neat to see some of these people some of my clients who came in, and some of the clients who were in the center, because we work as a team. Like, it's not just like me only working with one patient. Like, they would be going to group with, you know, one of my colleagues. They would be doing, maybe sometimes someone would be doing medicated assisted treatment with the doctor and seeing a nurse. They would be working with a case manager to find housing. Some of these people come in, they're homeless. They would be working with the peer recovery support specialist to find access to mutual support outside of the space. So that's cool. That's a reward. I mean, as a treatment facility, a system, working with a system, it's not just like, you know, needing to be this like all-knowing, all-powerful therapist, right? Which none of us are any of that. But it's like a team effort. So I found that very rewarding as well.
Yeah, I love hearing about the rewarding part, because I'm sure it's a very challenging job. Like you said, it's kind of a challenging population.
Yeah.
So, do you, Rochelle, did you have any more questions?
No, I don't think so. But I sure do thank you for sharing with us, because you've enlightened me with a lot of things that I did have questions about. So thank you.
You're welcome.
What about you, Vincent? Did you have any more questions?
Yeah, I had a question, but it seems like what you were talking was going to that line. But I will just lay it down and see if it's if you may want to say something extra to it again. My question was typically as a family and marriage therapy, because one thing I know about addictions is that it's one of those issues that people treat it with, family members see it with, attribute shame to it and disgrace and embarrassment to it, which is not like most other kind of psychological issues. And so I'm wondering how, as a family therapist, you get to get family members come around an issue that they are embarrassed about, and then come around an issue that they feel like it's a disgrace to their family. And often too, I've realized that addicted individuals are never really with their family sometimes, especially the younger ones. Maybe the married ones could still be, but the youth most often are like kind of like really straight out, and then mostly like doing things of their own, because family don't really care so much, and they themselves don't really care much about their family. Mm-hmm. And So I was just wondering how bringing family perspective into it, even in all those, I mean, when they're all pushing themselves apart like that.
Yeah. Yeah, that's okay. That's a big question. That's a really good one. I like, yeah. So you mentioned shame, you mentioned embarrassment, and then it also sounds like you also kind of, part of your question also had to do with, what about like kids specifically who have parents or families that just don't care? Like, is that awesome? So, okay, so I'm going to talk about the families first. So the families that the last. So I'm gonna start with the end and then come back to the other. There are a lot of times I had clients come in and their kids, and Oklahoma, OJA gets involved and they send them because they got in trouble. And family, some of them had family members that were coming too, and the child also just got involved with drugs and alcohol and had to be referred as well. And some of them, I think when some of the students came in and they had drug and alcohol, either addiction or just were having some problems with it. I mean, not all of them that came in were dependent, on the substance for like their they weren't having like intense physical withdrawals. A lot of it was marijuana, to be honest with you. And then methamphetamine typically was the primary drug of choice for many. And then alcohol kind of became some of that. But when families weren't involved, then part of the approach that we would take is helping them get connected to a community. And so if, I would always push, hey, having a family member attend. What about your mom? What about your dad? Is there anybody? But if they didn't have that support system around them, then part of that process was trying to help them find those motivators and those support systems outside of that. So school, employment, getting involved if they had, a certain faith that they, connected with, or, a church, then helping them find ways to connect and find supports there. And so that was kind of how we try to navigate that with them. And we have, and Gateway has probably one of the best like ways of helping people connect to the community and connect with wellness. I mean, we have this wellness coordinator, and gosh, she's amazing, but it's all about, there's a lot of research that supports that if people can have positive social connections, that it does show that it decreases the need to engage in addictive behaviors. And so if family members can't get involved, or here's another thing, sometimes family members are over involved. And so like teaching those family members maybe to back off a little bit and provide like maybe balanced support. And I know that's kind of a real subjective like way of saying it, but creating that can also impact it too. I think that kind of leads me into the shame and embarrassment part, because that is definitely a lot of emotions and that people tend to come in with, whether it's just a partner and their spouse, or a parent and their child, and depending on kind of like maybe their reputation in a community, or a context of the community, or just in general. Like there is a lot of shame that's associated with it. And noticing that shame tends to cause people to either like take control, and that can exacerbate the symptoms, right, of use, or it causes them to go, I'm done, I'm done with you, I'm done with, and they leave the system, or they just, they don't want to be a part of it anymore. And so part of the work that I would be doing with families is giving them space to be able to talk about that shame, because sometimes that shame and embarrassment, it's just not talked about. I mean, it's happening, and it's like this, it's the elephant in the room, right? And they come in with this elephant, and you have to part of the work after building rapport is helping those families address the elephant, and the elephant being addiction. And then when the person is going through treatment and recovery becomes part of their lives, this is something that Dr. Navarra is his name. He works with John and Julie Gottman and has created a component of couples and family. Well, I think it's couples, but he would say it works with families, couples and families in recovery. He would say that recovery even itself can actually sometimes be the elephant in the room. And so helping families navigate the shame, the hurt, the pain, which is trauma. I mean, for many of these families, like either trauma was a part of people jumping into drug and alcohol use or substance use or addiction, or there was trauma that happened during it. But part of that process is giving them a space to be able to talk about it without it like further creating more shame, but that the family's working together as a family unit, working with a person who may have the substance use disorder, work together. So if there's kind of some externalizing that I have been trained to do, is let's externalize addiction, let's externalize recovery, and as a family, let's use that to bring the family system together to help this process. Because a lot of times shame is kind of the energy that keeps all of that yuck going. It's what sometimes draws people back to substance use or addictive behavior. And it's what also causes some of the family members to start over-functioning or under-functioning. Oh my goodness, yeah. So.
I really liked how you talked about the over-functioning. That was kind of a surprise to me. I guess I could imagine parents who were uninvolved, but that was kind of a new concept to think of, helping families release their over-functioning patterns or whatever, and to step back a little bit. That was very interesting.
Yeah.
I had 2 questions real quick. We've got about 8 more minutes. I was really curious to see if you've incorporated any of your experience with art. You talked about the therapeutic benefits you noticed in your, what was it, high school students or something. Have you ever incorporated that with your current work?
Mm-hmm. Yeah, I have. I did it more with groups, but then there were some moments where I got to be able to use that modality as maybe an intervention with families. With groups, art tended to be kind of the way to help people lower some of their defenses coming in. Group treatment can be very powerful for people who have substance use disorder or co-occurring, or just other mental health related problems too, because they're in a room with other people who share some similarities. But sometimes what can happen is they can also come in and they can, depending on how they're feeling, how much abstinence they've had from a substance, they can be on guard and very defensive. And I kind of noticed that sometimes giving them like an activity to draw, like, I don't know, one time I just came in and I was like, hey, I want everybody to draw your family doing something, whether that's your family of origin or your family of, your family, like you and your kids. And I didn't realize how powerful that was, but they, some of them, they're all like, I don't like to draw. And they just kind of humor me and, draw the stick people. But it was really interesting because the power was when they started talking about it, because when they took the picture, they could, it was here. It wasn't like in here anymore, and I just asked them to just now, if you feel comfortable, let's go around, tell us what you and your family are doing. And so they went in, and man, when they just get to just talk about this picture that they drew and chuckle a little bit because, they have a big head, that they drew or something, but then they start like talking about what they're doing. I mean, it created opportunities for them to have emotional expression and lower defenses that would have been very different than if we were just sitting around just talking. So I have found that working sometimes with the population of people that have substance use, that the shame. So I just think I'm gonna come back to that. That shame tends to pride tends to be sort of this barrier, and having someone just sit down and talk can sometimes be a barrier too, because they need to act, they need to move, and maybe it's biological, maybe it's, psychological, maybe it's social. It's probably all of that, right? But if you can find an outlet, sometimes it's kind of strategic in some ways, is that it's kind of a strategic way to give them an opportunity to relax and open up. And so I don't know, I kind of think of it, if you've ever been to a chiropractor, I don't know, or done any physical therapy, sometimes they kind of like, rub your back or put biofreeze on you, and it just helps you relax a little bit so that they can create a little bit of movement. And I think that I don't know, I found that art to do that, whether it was drawing or it was movement, like with kids, teenagers. A teenager, for me, if I just sit in a room with them and talk to them, I'm just this weird guy, bald-headed guy in this room with these teenagers, and I don't look like a teenager. I'm older now. They don't want to talk. But if we'll go outside and play basketball or throw a ball around, or go on a walk, I mean, just the movement, and I don't know, it gives them space. They don't feel put on the spot, and that happens when they're, I think, 14, 15 or 40, so yeah.
Nice. I love that. Everyone already knows this in the program because I talk about it constantly, but I love dance and I love like movement therapies. So that's really, really cool to hear.
Yeah.
My last question was I just love a good story. Like, do you have a particular client or case that just showed some really special or rewarding or remarkable change that you could leave us with, just a mini story?
Sure. Man, there's a lot. Okay. Yeah, I'll tell you one. So, there was a client that I had, probably about when I first started. They were mandated. DHS had gotten involved and removed the kids. And when the individual came in, they had already lots of past experiences of being in and out of treatment, and those had not, for whatever reason, stuck. They were going back and engaging in their addictive behaviors. And as a result of this time, they had a child, and that child was removed from the home. So, working with this person, I mean, it was really all of them. I mean, they were separated from their partner, but it took them a while. And usually in the DHS system, sometimes after 90 days, if there isn't any movement, most of the time DHS workers will move to have the child put in more permanent placement and up for adoption sometimes. And this person's DHS worker was working really hard with the family. They were also Native American, so the tribe was also trying to provide some supports for them. And it took this family, this couple, a year, probably took this person a year before they started becoming more motivated. They were engaging in treatment, but it was very limited. But something happened at a year. I think it was when the tribes and the DHS had said, "Look, your child is going to be removed from your care permanently." And for whatever reason, they started engaging. They got actively involved, but it took them a while. They had polysubstance use disorder, so there was more than one substance that they were having problems with. And oftentimes with clients is that if they stop using one substance, they will substitute for a secondary substance or addiction. And this particular person, I mean, they had 3. So it was this substance that they primarily came in for, and then they moved to the second one, and then they had to move to this third one. And the third one was what they started with when they first started their addiction. And it took this person almost 2 years with work. And I mean, they would come in, I didn't really feel like I was doing much when I met with the individual, because it was like sometimes 30-minute sessions, and most of the time they would just come in and gripe and about how horrible and humans these DHS workers were, and da 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 da. This person didn't have like these moments where they would just like cry and have these emotional experiences that sometimes validate us, as, or at least me as a therapist, that, oh, change is happening. It wasn't. I mean, this person was kind of just, I don't know. But they stayed stuck with it. They kept moving. And there was slow movement, slow movement. And took about 2 years, and sorry, I'm trying not to give away any identifying information. The person communicated to me that they were in the process of reunification with their child. And they came in and they were so excited, because I don't think they thought that this event was going to happen. It was surprising to me that this person, that DHS and the tribe, was advocating for this family so much, because many you will find it, they don't get their kids back if it's a DHS referral, that children get removed. And this particular person, and I think a lot had to do with the tribe was advocating very heavily for them. But it took them about 2 years, and they started reunification, which reunification is where DHS will put the child back in the home, and it's kind of like they start off with like a weekend, and then maybe 3 days, and then 4 days, and then they give them this 6-month period where their child's back in the home, as long as there's not any reoccurring problems and safety. And so anyway, sorry I went over, but that's been probably one of the more powerful experiences for me. And that family is still working and doing work to have their child. This particular person's personality was scary to me at the beginning. I didn't think that they probably were giving their child as much love as I thought they should have been, but I had to really change my view and perspective on that and grow. And so it was a growing experience for me. And then once I got to actually work with the family and the kid, oh my gosh, this individual was not the same human being around their child and their spouse than they were with me in the room. And it was so cool to see that. And so that was really cool. So.
Thank you so much for sharing. I liked how you kind of showed to us tonight that change can be slow, but that's okay. It sounds like that was a very slow process for the client, but helps us to remember not to like get frustrated or to rush through things, and just give them time to figure it out.
Definitely. God works in mysterious ways.
Yeah. Absolutely. Well, we want to thank you so much, Mitchell. You have given us so many resources. I took 3 pages of notes. And I know there's a lot of students who couldn't be here tonight, and they're looking forward to the recording, and they are just going to learn so much, because I know I learned a lot of resources and things that I need to now go Google. So I'm excited.
Well, you're welcome. And if you guys have questions, or if any of those that are listening to this or watching this, if they choose to do that in their busy schedules, if I can be a resource or can answer any questions, I'd be happy to. You're welcome to share my email or whatever, and I can figure out a way to get in contact. So yeah.
Okay. Well, thank you
for you all.
Thank you
so much.
Yeah. Nice to meet you.
Appreciate your time.
Thank you.
Have a good evening.
Good night, everyone.
Have a good
Thank you very much.
Thank you.
Bye.
Bye.